Hello everybody, welcome to our lecture on asthma, also known as chronic airway inflammation. By the end of this, you should be able to define asthma, understand its pathophysiology, explain the underlying mechanisms, recognize common triggers, diagnose it clinically and with investigations, and understand management. So what is asthma? Asthma is a chronic inflammatory disease of the airway. It is characterized by airway inflammation, bronchial hyperresponsiveness, variable airway obstruction, which causes the classical wheezing, and then the narrowing of the airways, which is reversible. In COPD, called chronic obstructive pulmonary disease, it is similar to asthma, but the narrowing is typically not reversible or not as reversible. There is a degree of permanent damage. Asthmatics often present with recurrent episodes of coughing, feeling short of breath, wheezing, feeling a tight chest, and could even have lowered SATs. The global impact of asthma is quite extensive. It is one of the most common chronic diseases in the world, affecting all income classes and age groups. It's one of the leading causes of absenteeism in work and school. It's one of the most common emergency room visits, and overall, it affects about 300 million people in the world. So, how do normal airways work? Normal healthy airways have thin-walled bronchioles, thin-walled bronchi, minimal mucus production unless inflamed due to illness, relaxed muscles, and free airflow. Air can move freely from the nose to the trachea to the bronchi to the alveoli and back again, vice versa. However, in asthma, that is not the case. Asthma has three core problems: inflammation, bronchoconstriction, and excessive mucus. Inflammation. Airway inflammation persistently can lead to swollen edematous airway lining and an increased amount of your inflammatory cells, such as eosinophils, mast cells, T helper cells, and basophils, and it can lead to an increased amount of mucus production. Swollen edematous airway lining means less space for air to move. Then you get bronchoconstriction. Your smooth muscle contracts excessively, can lead to rapid airway narrowing and reduced airflow. Common triggers for bronchoconstriction are allergens, usually inhaled or contact, but food allergies can also be important. Exercise is a trigger for a lot of people. Cold air, infection, and smoke exposure. Then excessive mucus production is normally caused by your goblet cells producing more mucus than is normal, normally in response to a trigger. Airways become quote unquote clogged and airflow is reduced, and that increases your work of breathing. As you can see in this triad of inflammation, bronchoconstriction, and mucus production, the core principle is reducing the amount of airflow. So here's a nice little diagram of a normal versus an asthmatic lung. You can see in a normal airway, you have a nice smooth muscle layer that's relaxed, nice wide lumen to allow as much flow as possible of air. In the asthmatic lung, constricted airway, tight and smooth muscle, thick, inflamed, hypermucus sort of environment. So why do these patients wheeze? Wheezing occurs when air moves through narrow spaces. Think of blowing through a wide straw versus a narrow straw. In a wide straw with a normal lumen, i.e. normal lumen, as our analogy goes, you have easy airflow and large volumes. Very easy to blow through a wide straw, almost makes no sound. In a narrow straw, i.e. our constricted lumen, you get turbulent airflow, lower volumes of air moved with more effort, and also typically has a more pronounced sound. The turbulent airflow is that causes the characteristic wheeze. So why the short of breath, the SOB? Airway narrowing means increased resistance to flow, and increased resistance to flow means reduced expiratory flow. So it's harder to breathe in, but it's even harder to breathe out. The inspiration-expiration mismatch causes air to not be fully expunged, which can lead to air trapping and a thing called dynamic hyperinflation. Think of it like the straw analogy again. Narrow straw breathing is harder and more tiring than wide straw breathing. With the inspiration-expiration mismatch and hyperinflation, it can lead to a thing called stacking, which is where, say, I breathe in 20 units of air, and I only manage to breathe out 15. That means I still have 5 left over. Then if I breathe in another 20 and only manage to breathe out 15, now I have 10 left over. And this stacking can in turn cause me to be able to breathe in less, but still breathe out less. And it's a very dangerous game to be in. So what is the allergic mechanism of asthma? The vast majority of asthmatics have an allergic component to it. Your common allergens are your dust mites, such as pollen, pollen, animal dander, and mold. IgE antibodies in your airway recognize the allergen. Your mast cells activate and release histamine and leukotrienes. And then the histamine and leukotrienes cause inflammation, and that can cause bronchospasm. Common asthma triggers are your allergens, like we said in the previous slide. Infections, normally pneumonia if it's bacterial, or influenza and RSV if it is viral. Physical triggers such as sudden weather changes, cold air exposure, or exercise. That being said, asthmatics can still exercise, they just need a more tailored program and different progression that we will get to in a different video. Emotional triggers such as stress and anxiety, especially if you have concurrent panic attacks, that can worsen your asthma. And then medication, NSAIDs such as ibuprofen directly can trigger asthma, and then aspirin and beta blockers as well. So how do you diagnose asthma? It is based typically on clinical history and objective evidence of airflow obstruction. Your gold standard is spirometry, testing your FEV1 and your FVC ratio, and then testing a bronchodilator response. And then peak flow measuring is also useful. So how do we classify an asthma exacerbation? Intermittent, symptoms less than twice weekly. Mildly persistent, more than twice weekly. Moderately persistent, symptoms every day. Or severely persistent, which is continuous symptoms, frequent exacerbations, very rarely at baseline. And then we get phases of asthma. And this is essentially progression of an exacerbation. So your early phase is your symptoms begin within minutes of exposure to something. It features your bronchoconstriction, feeling of tightness, and can have wheezing. Your late phase, often only is a few hours later, features ongoing inflammation, mucus production, non-resolving symptoms, increased work of breathing, and typical ER or EC presentations are in the late phase. You'll often find patients say, oh no, my chest started feeling tight this morning, or started feeling tight last night, things like that. The reason people present in the late phase is because most of the time asthmatics who are treated have pumps. They take their pump, feel a bit better, but in late phase they have ongoing inflammation and non-resolving symptoms, prompting them to come get checked out. It's important to differentiate the severity of your exacerbations. So we have frequency of exacerbations, phases of exacerbations, and then severity of exacerbations. It's important to be able to grade or get a general idea of the severity to ensure prompt treatment. A delay in treatment can cause severity progression, which can lead to status asthmaticus, which is life-threatening. Your signs to look out for: mild exacerbation is wheeze, slightly tachypneic, tachypnic. Then moderate exacerbation would be accessory muscle use, heaving chest, lower rib sucking in, rocking in the chair, can have difficulty speaking and a drop in their SATs percentage, and so would be short of breath at rest even. Then you get severe exacerbations. They are markedly distressed, further drop in SATs, can't complete sentences. And then life-threatening, either cyanosis of fingers and lips, altered mental status, i.e. confusion, loss of consciousness, or a silent chest, i.e. no wheezes because of complete cessation of air movement, because enough constriction means means the bronchioles are fully closed, means no air whatsoever is moving. If an asthmatic patient has a silent chest and they are not talking to you and are not conscious, if I can call your senior. Overview of asthma treatment. Your goal is to prevent symptoms and exacerbations and maintain lung function, improve quality of life, and prevent airway remodeling and long-term complications. Treatment is, again, like most things, can be lifestyle and medication based. Medication, get your short-acting bronchodilators for rapid symptom relief, commonly called relievers. Your controllers treat chronic inflammation, and your long-acting bronchodilators and other medications can be used as adjuncts. So lifestyle changes. Exercise, adequate warm-up, using your inhaler pre-exercise if needed, and having good baseline continuous asthma control is important. Avoiding triggers, so reducing exposure to dust, smoke, and other allergens. And if you do smoke, please stop. That's it. Please just stop smoking. Allergy testing can be especially useful to identify triggers, including food allergies, so important. Weight management. Obesity worsens your symptoms, worsens control, and worsens exacerbation risk and severity. And vaccinations are recommended. Your yearly influenza vaccine helps prevent RSV and influenza infections, means helps prevent exacerbations. So what are medications? Short-acting bronchodilators, called our SABAs, often come in as mono-inhalers for use as needed. That's your salbutamol and albuterol, usually 1 to 2 puffs if the patient feels wheezy or feels a tight chest. You do long-acting bronchodilators, your LABAs, often combination inhalers with inhaled corticosteroids and a long-acting bronchodilator for once to twice daily use, such as your budesonide formoterol, that is Symbicort. Then you get fluticasone and salmeterol, piclomethasone and formoterol. Again, what you use depends on guidelines, what's available in your specific country, etc. Leukotriene receptor agonists, such as montelukast, can be a helpful adjunct in poorly controlled asthmatics because they block your leukotrienes and histamine from binding to airway receptors, and that reduces inflammation. Antihistamines don't directly treat bronchospasm, but they can assist with control in allergic asthma because they reduce airway inflammation. Ideally, non-drowsy once-daily types are preferred, such as your cetirizine, desloratadine, fexofenadine. The fewer pills a patient needs to remember to take, the better for compliance. And then you get your long-acting muscarinic antagonists, or your LAMAs. They block acetylcholine on your M3 receptors in your smooth muscle and causes a direct relaxation effect. That's your ipratropium and tiotropium. Emergent management. Exact management depends on your state, country, hospital, etc. But the goal of your therapy is to maintain appropriate saturation of oxygen, i.e. your SATs, dilate your airways to allow free movement of air as much as possible and reverse inflammation. So, step 1, oxygenation and nebulization. If someone comes to you in the EC with a moderate to severe asthma exacerbation, oxygenate, nebulize. Commonly nebulized medications are salbutamol, often available as a salbutamol solution or in combination with budesonide or ipratropium. Commonly nebulized is also adrenaline, so it can act directly rather than systemically on your bronchioles for dilation. And magnesium sulfate can also be nebulized. It's usually more common in the pediatric setting. It has a more direct activity on your airway smooth muscle receptors with fewer systemic effects than IV or IM Magsulf. However, important to note, especially for your more adult patients, that inhaled Magsulf can be a little bit uncomfortable. It can make you feel a bit warm, flushed. Just warn patients of those sort of effects. In the event of severely low SATs, decreased GCS, nasal prongs can be put on under your nebulizer to enhance oxygen delivery. Corticosteroids reduce active airway inflammation and enhance nebulization effects. These are not part of chronic management because chronic corticosteroid use can lead to metabolic dysfunction and Cushing's syndrome, as an example. But orally, you typically give prednisone in a 20 to 40 milligram stat dose, continued for 5 days post-discharge, depending naturally on the person's body habitus. A 200 kilogram person with an asthma exacerbation might need 50 or 60 milligrams of prednisone. A small 50 kilogram lady might only need 30 milligrams of prednisone. And then prednisolone, usually used in pediatrics because it is normally the syrup formation, at 1 to 2 milligram per kg of a stat dose, again continued for 3 to 5 days post-discharge. If the GC is too low to swallow, or if it is a severe attack, dexamethasone and betamethasone can be given IM or IV at those doses. Also part of corticosteroids, hydrocortisone can be used as well, normally at 100 to 200 milligrams. Hydrocortisone can be dosed 4 to 6 hourly as needed, but it is less effective than a single dose of dexamethasone or betamethasone. But it is a lot cheaper and more widely available. Magnesium sulfate, like we said earlier, can be nebulized for more direct receptor activation, but it is normally not the first line nebulization. IV administration is useful in severe asthma with poor response to initial therapy. It causes smooth muscle relaxation, it's mildly anti-inflammatory, and it reduces your severity of bronchospasms. It can be given IM if IV access can't be obtained, but your patient will hate you because IM magnesium sulfate burns terribly. It is typically dosed at 2 grams of magnesium sulfate in 200 milligrams of normal saline, given over 15 to 30 minutes. It can be given faster, but because of the smooth muscle relaxation, it can also cause a drop in blood pressure. So it can cause a significant drop if given too quickly, so using caution in those with low BPs. And also, like with the inhaled version, it can cause flushing, dizziness, feelings of warmth, those sort of things. And then lastly, you get theophylline. Theophylline is last line because it can have severe side effects if it reaches toxic levels. Typically dosed at 5 mg per kg up to a maximum of 500 milligrams at a rate of 25 milligrams per minute. It's contraindicated in patients with obviously a known allergy or those with a sensitivity to xanthine derivatives, i.e. people who can't use theobromine, people who can't use caffeine. Use it in caution with seizure disorders because it can lower your threshold. Use theophylline with caution in those with peptic ulcer disease because it can increase gastric acid secretion. Use with caution in cardiac conditions, such as recent infarction, ACS, or arrhythmias. And then medications such as erythromycin, hormonal contraceptives, and quinolone antibiotics. They can all increase your concentration of theophylline, i.e., by lowering the breakdown of it. And then medications such as phenytoin, rifampicin, carbamazepine, they can reduce the efficacy by enhancing the breakdown of theophylline. Then some helpful adjuncts. Ketamine. Low dose ketamine can be used off label in severe asthma because it can act as a bronchodilator. 2 hour dose can cause sedation. And then typically that's dosed at 5 to 20 milligrams IM or IV. Or if you have a nasal spray available, that is also preferred even. Antibiotic stat doses are useful if the exacerbation is likely infectively mediated, such as if you suspected pneumonia. Augmentin 1 gram per, amoxicillin 45 to 60 milligrams per kg per hours in children, or ceftriaxone 1 to 2 grams IV or IM. IM ceftriaxone burns. Antihistamines are less for the acute management, but they can be useful for concurrent allergic symptoms. So if someone has an asthma attack secondary to an allergen exposure, an antihistamine can help sort of prevent the progression of an attack from a mild, moderate to a severe. It won't reverse the problem, but it can help slow progression. And that's your cetirizine, 10 milligrams, promethazine slash Phenergan, 10 to 25, and your chlorpheniramine, 4 milligrams. Promethazine, however, can be sedating, so the 25 milligrams is not preferred. And then fluids, and fluids, unless contraindicated. Lastly, intubation and ventilation. If your things do not work, if all else fails, you will need to intubate the patient. Signs leaning towards intubation would be GCS not improving, even though there is no silent chest. If they do have a silent chest, they are not responsive to multiple nebs, magsulf, theophylline, corticosteroids. If the SATs are not rising in spite of adequate nebulization and other medications, and if their blood gas is showing signs of respiratory failure. You want to not be in this position because due to the hyperinflation and airway resistance and air trapping, asthma exacerbations are notoriously difficult to ventilate. So your common sequence of events would look something like triage, blood pressure and SATs, and assessing the severity, getting 1 to 3 nebs and reevaluating. If no minimal response to nebulizations, we receive a dose of corticosteroid, and then another 1 to 3 nebs with reevaluation. If no response after the second round, IV magnesium sulfate, and then continue the nebs again. Once more, if no or minimal response, consider IV salbutamol or continuous back-to-back nebs. Also consider maybe an IM adrenaline injection, 1 milligram. And if they deteriorate in spite of the above, consider your theophylline or intubation. Just note, sometimes patients need more nebs than you think. Sometimes patients can get 3, 6, even 9 nebs and still be wheezing. That's okay if they are awake, talking to you, did not look severely distressed. Just keep on the nebulizations and they will come right at some point. So what are our take-home messages? Asthma is fundamentally an inflammatory airway disease. Its main mechanisms are inflammation, constriction, and mucus production. Inhaled corticosteroids are the cornerstone of long-term management, not oral corticosteroids. Those are your LABAs. Then your SABAs, such as salbutamol, treat your symptoms but not your underlying inflammation. Severe asthma can very quickly become life-threatening. Rising carbon dioxide, exhaustion, and silent chest are emergency warning signs. Good inhaler technique, Avoiding triggers and medication adherence prevents most asthma exacerbations. Thank you for listening. I hope you learned something about asthma.